Hello, everybody. Welcome to this case from Medstream in La Paz Hospital in Madrid. My name is Santiago Jiménez Valero. Here in the Cala with me, there are our two nurses, Isabel and Alicia. And our fellow Danny Tebar will present you the case that we are going to show you today.
Okay, so good morning, everyone. We present a 67-year-old man with a medical history of hypertension and dyslipidemia. He experienced an acute cerebrovascular accident in 2012 and was diagnosed with chronic coronary disease in 2007, which revealed a chronic total occlusion in the left circumflex artery and severe stenosis in the right coronary artery that was treated with a conventional stent. During this admission, he presented with unstable angina. Echocardiogram findings show a left ventricular ejection fraction of 40%, with akinesia in the inferior region and hypokinesia in the anterior region. The treatment plan consisted of dual antiplatelet therapy, atorvastatin, ezetimibe, bisoprolol, empagliflozin, enalapril, and eplerenone. So, in the current coronary angiography, we can observe severe intrastent restenosis in the right coronary artery. Additionally, there is an angiographical stenosis in the left main coronary artery caused by a calcium nodule, which was later confirmed by intravascular ultrasound IBUS with an area of 5 millimeters. During the initial procedure, guided by IBUS, revascularization of the left main was performed by implanting a 4.5 millimeters diameter stent, which showed a favorable result according to IBUS with a minimum stent area of 10 millimeters. In today's procedure, we will evaluate the intrastent restenosis using optical coherence tomography, OCT, and decide on the course of action based on the results obtained. So, Santi.
Thank you, Danny. Okay, pues in resuming the case, is a very old restenosis, more than 15-year evolution of a restenosis of a bare metal stent. Danny have shown the image. Is a focal restenosis in the distal right coronary artery. Our approach is radial access with a AL1 guiding catheter, 6 French. And our first approach will be to perform an OCT analysis. Let's try without dilatation to obtain a better image of the lesion without modifying with balloon. But it's possible that if the catheter or if the dragonfly catheter is occlusive, we will need to predilate.
No podéis tocar esto.
Ponle. Marc, deja eso. Vete conmigo.
Que no le van.
Can I show you the image of today? ¿Podemos enseñar las ángeles de hoy, Dani?
So this is the angio. We can see in the distal right coronary the lesion.
The proximal and mid part of the right coronary artery have important calcification and moderate angiographically lesion, and we will try to evaluate also with OCT this part of the vessel. We are advancing the OCT catheter. You can see it is difficult because of the calcification of the mid part of the right, even when we have high support with the catheter. So give me please a 2.5 balloon.
2.5. 2.5 balloon.
2,5, un 15 o así, Isabel. For this case, having in mind the long-term evolution of the restenosis, we have prepared a laser catheter, excimer laser catheter. If it's necessary, if we find some calcification of the neointimal tissue, I will try to predilate softly the mid part of the right, and if it's necessary, we will advance an extension catheter to try to obtain the image of the restenosis in the distal right coronary. No tenemos. Dígame, Dani,
Dime.
mira si tenemos algún extensor de catéter guía aquí a mano, porque a lo mejor lo necesito.
No lo abro, no.
Un toquecito. Test. Vale. Infly states. Vale. Infly states. 6 atmospheres. ¿Sí? 12, 14, 16. This is a significant infraexpansion in the mid part. Infly 12. Okay. Aquí otra vez. 12 también. Okay. Let's try to advance again the OCT catheter. Ok, dame un telescope, por favor. Then it's difficult to advance the OCT catheter. We will try to advance with the use of a guide extension. We will use a telescope catheter. Déjame el baloncito de 2,5. Ya, por favor, gracias. Dale negativa, por favor. Vale, inflay un poquito. Inflay 4. Sí. Vale, desinfla. Okay, we have, with a bad technique, we have advanced the telescope to the mid part of the right coronary artery, and then we will try to perform the OCT pullback. Una gasita, por favor. Todo retorcido. Así. Okay. The OCT. Un toquecito, por favor. ¿Tenemos el pullback largo, Dani?
Yes.
Okay.
Now.
Let's retrieve a little the telescope catheter.
Yeah.
Be careful with the wires. Oh, espera. Vamos a retirar un poquito. Por ahí.
Okay.
Vamos a poner 12:3 porque we are going to inject with the telescope, so it's a selective injection. It's necessary a less amount of contrast, 12 to 3 milliliter second. Okay. Es que no veo. No, I can't see the OCT.
We can
Test. Okay, we are clearing the vessel.
Yeah.
Okay.
So, starting the sequence.
Contrast.
Good.
I go there to review the image with you, Danny.
Okay.
Es al revés, próximo. proximal a distal. Let's review the pullback from distal. This is the distal part of the stent that it's located in the posterior descending artery. You can see in some points there are calcification of the neointimal tissue. You can see here, for example. And this is the most severe region. Probably there is also calcification in this point. There's a lot of fibrous tissue also. And we have seen with the predilation that there was a very strong lesion. So we will use laser excimer to prepare this lesion before high balloon predilatation and stent, if necessary. The other option is to perform finally only balloon with drug-eluting balloon. Sorry. The mid part of the right have also superficial calcification. You can see some pools of calcium, not a severely calcified artery. Some nodular calcification, but without the stenosis of the lumen. And this is the proximal part. There is a significant calcium nodule that difficults the advance of the OCT catheter. So this is the reason why we have needed to use a guide extension. But you can see the area in this part is good. I think it's not necessary to treat. This is the telescope catheter inside the coronary. Okay. Well, but let's prepare the laser catheter, please. First of all, we have to calibrate the console, the OCT, the laser console. So, Danny, can you help us?
Yeah. Oh. So I was making the measure of the stent, and the diameter is 2.75.
No, miro. I don't know if all of you can see us. Danny is preparing the laser console. The first step is to calibrate the console with a non-sterile catheter. He's calibrating now. In this moment, we cannot see the light of the light laser. We should use protective glasses, sunglasses. And now we open the sterile catheter and calibrate again. Esta parte para Dani. Y aquí cogemos con el mosquito lo que te decía antes, ¿vale? Espera, vamos a hacerlo al revés. Vamos a darle primero esta parte a él. Sujétame, por favor. This is for you, Dani. Sujétame esto por este lado y esto para que no se nos caiga.
So there is no sterile segment of the wire, or of the laser wire, and there is another sterile segment.
A ver si puedes con las otras. Ok. Cuando me digas.
So the machine is pre-calibrated with a used catheter, and now we need to calibrate the real catheter again. This time sterile by the operator.
Okay, the catheter is ready. So we have a telescope here, so we are going to use it. And el balón de 2,5. I'm going to advance with the balloon and let the telescope prepare to advance the laser catheter. There are several techniques to apply energy and laser energy. The best is a constant clearing with saline to avoid complications. It's a safer way. And in case if necessary, you can perform without saline or even with contrast to obtain a high power to modify resistant plaques. Inflame. Espera un segundo, estoy dentro todavía. Inflame ahí, 4, 6. Vale, desinfla. Ok. This is the laser catheter. It's a coaxial catheter. Sorry, a monorail catheter. 0.9, and it's the catheter that allows to apply the maximum energy and the maximum pulse repetition. So deploy the maximum energy. Sorry, can you quítame las gafas, por favor? Gracias. Here is advancing the laser catheter. We are now in the lesion. So in this point, we start to flush with saline and apply energy. Let's start with 60-60. The two parameters are the fluence, that is the intensity of the energy, and the other parameter is the rate, the pulse per second. We are starting with 60 and 60. Okay. Suero. Now we are applying laser. Paramos, hay un poco de contraste. Vale, lava con suero. Ok. Suero. We advance slowly. The system give a note to give us that it's ready. Suero. Suero. You can see the catheter has crossed the most severe part of the lesion. We are applying laser also in the back part of the artery. Let's do another passing. ¿Qué pasa, Francisco? Vale, vamos a hacer otra. Suero. Vamos a hacer otra en retirada. Okay. Well, this is the first balloon inflation. You can see the under expansion. Let's make a test, and we will use again the same balloon and dilate in order to observe if the effect of the laser energy has been effective. Déjame el balón de 2,5 otra vez.
So we have
Un tercio.
one message from Ashline. Alfonso Jurado says that we are a great team and greetings from Iceland. He's on vacancy today.
Thank you, Alfonso. Enjoy your holidays. Inflamos ahí, por favor. Vete inflando. 8. This is the inflation at 8 atmospheres. Retira. Vamos a dar un poquito más. Dale ahí 12. And 12 atmospheres, the same pressure than before. You can see that the balloon expansion is now it's better. So let's do a new OCT. Danny, please, the short pullback.
Yep. Okay. So
Patient has had some pain, and you can see now the ECG is elevating the ST segment. Maybe that there is some embolization of the breeze after laser. We are treating. Dame nitro, porfa.
So let's make another OCT.
Yeah, I will make an OCT and retrieve the telescope.
Sometimes with laser we see dissection of the vessel, and sometimes it makes chest pain in the patient. So let's see.
Dissection to the OCT. Do you see, Danny? Do you set dissection to the OCT?
No, with the laser.
Laser. Oh, okay.
Yeah.
Okay, let's retrieve the telescope catheter. Give me some nitro, please. So I'm going to retrieve also the guide wire. Vale, un test de contraste, porfa. Un poquito más. Vale, pues vamos a ponerlo otra vez 12:3. ¿Estamos? ¿Estamos, Dani?
Sí.
Vale, contraste. Vale, vamos a sacar todo y revisamos. ¿Qué tal, Francisco? Ven, enseguida te vas a encontrar mejor, ya verás. Da un poquito más de nitro y un par de jeringas de suero. Okay, it seems that the ST elevation is going down. Test, please. Cine, por favor. Okay. ¿Se va pasando, Francisco?
Look at this. We can see some dissection in the more stenotic vessel segment of the vessel. From proximal to distal.
There is some probably due to the balloon dilatation. It's not a.
There, maybe.
We cannot. We usually with laser don't see large dissections, large calcium fractures, like other techniques, like for example, shockwave. But you have seen the effect on balloon expansion. To be sure, we are going to dilate with a non-compliant balloon. Let's see the effect and decide if we implant another stent. ¿Me das un no compliante de 3? Ponle 2000 más cuando puedas. Francisco, ¿cómo estás? ¿Ya mejor? Ya se ha pasado, ¿verdad? Venga, fenomenal. 12. 3.30 and 15, okay. Sí.
So the ST elevation is now completely normal, and the patient has no more chest pain. So
Inflay 16.
this was temporary.
Aguanta un poquito que voy a mirarlo en otra proyección. You can see the balloon expansion in two projections. Looks good. Desinflamos. Eso queremos, Francisco. Well, but at this point we have to decide if we implant another stent. Remember that this is a very late stenosis of a bare metal stent, so I think it's if we treat it like a normal restenosis of a bare metal stent, we should implant another stent, and I think this could be the best option. What do you think, Danny?
Well, there are two options: this or drug Latin balloon. I think the best option in this case is to implant a stent and
Okay,
and
then
try to
was
finish.
3.5, un 3.18, porfa, Sten. According to the diameters of OCT and the balloons that we have used, we have chosen a 318 Sten,
Yeah.
3018.
So we have a question about our experience with laser in cathephylated lesions. If we have experience and good experience at all.
Yeah, we have some experience in this point. Mainly my colleague Alfonso Jurado, it's an expert in this field. We are working in a randomized study comparing rota, laser, and shockwave, and according with the indications, it seems that laser would be not the best option for severe calcification, but in our experience, it works. As I said before, you can see with image techniques no large fractures, no big ruptures of the calcification, but laser in some way modify the response to dilation that makes the plaque more easy to dilate, and we have seen good expansion after laser in severe calcified lesion. Also, an important issue for laser is the underexpanded stent. This is not the case, but we have seen with OCT that the stent expansion is good.
Yeah.
But in cases of restenosis due to underexpansion, laser is also a very good alternative and allows to, after therapy, to expand the stent with a non-compliant balloon.
Yeah, you have just answered the second question about our experience in intra-stent restenosis. That is very good too. Due to infraexpansion more than.
Again, in the calcium nodule of the mid part, we have some difficulties to advance the stent. Let's use again the telescope, please.
So laser seems to change the break properties and the calcium properties, destroying some bridge.
Yeah, the laser exert some effects on the calcified plaques through photochemic, photomechanic. There are several mechanisms. Okay, and the fact is that the plaque is modified, and you can dilate properly a lesion that was undilatable before.
The point is that sometimes you don't see nothing new in the image, in the intracoronary image, and you say, well, we did nothing here, but we really made.
Okay, ponlo ahí. $12, $14 y $16. 16 atmospheres. Expansion looks good.
Yeah, very good expansion.
Okay. Let's advance the telescope to make a final OCT. Okay. Another more question, Danny?
No, there are no more questions.
I would like to know the opinion of the audience about how many operators would have decided to use only balloon, drug-eluting balloon.
Yeah, this is a good debate.
Okay, we are there. ¿Le das, por favor, Isabel, a continuar? Ahí abajo a la derecha. Purgamos 12:3, ¿vale? Dame un tesecito a ver si se lava bien. Vale, voy a retirar el telescopio. Ok, vale, pues comenzar. Contraste. Okay, let's review the OCT pullback. Próximo a la vista.
Es que nunca funciona.
You can see the space between the two stents because obviously the tissue don't disappear, but the stent seems to be good span, circular. Some tissue before the bifurcation, proximal to the bifurcation. There's some moderate restenosis, but I think it's there is the ostium of the posterolateral branch. You can see at 11. You can see here the ostium of the posterolateral branch with uncovered struts. This is the posterior descending with some calcification, but not a significant lesion. This is the moderate restenosis of the distal right coronary, proximal to the bifurcation, and there is the new stent. You can see it is circular, well expanded, but in some areas you can see the previous stent and the calcified neointima between the two stents. We can measure the expansion. Proximal 3.5 to 100. Okay. You can see the software analyzes the expansion of the stent is very good in all the length of the stent between 19 10%. And you can see the minimal stent area is always not in the distal part, but in the mid part. It's below 4.8. As you see, as you know, but the consensus of the OCT, we should obtain always large than 4.5. Okay. I think the result is good. I think it's better not to go distally to avoid treat the bifurcation. You can see the ostium of the posterolateral branch is completely free of plaque. In the angio, we see some plaque in the ostium, but you can see in the OCT it's preserved. So I think we were going to finish the case here. What do you think, Danny?
Yep, I think the result is very good. The laser work fine, and the stent result is good. So we can finish. And like the patient said before, he has new coronaries.
¿Qué tal, Francisco?
Nearly new.
Estamos terminando, ¿vale? Sacar esto. Vale, ponemos un poquito de nitro. Vale, un poquito con contraste. Vale. ¿Cine? ¿Otro cine? Well, it's all.
I think this is very good result. The angios sometimes lies, but not in this case. I think.
Probably there's some plaque, but not exactly in the ostium, but in the proximal part of the PL. But as we see it in the OCT, the access is free. I think it's not necessary to treat this branch.
So thank you very much.
Thank you
to everybody.
Ya hemos terminado.
And see you
Le hemos
in
puesto
the
otro
next
stent
case
en la zona donde estaba estrecho el stent
Spain.
anterior.
Bye bye.
Le hemos puesto otro stent.